Vanki, thank you so much for the kind invitation. And as usual, you gave me a tough topic to talk about, why the venous ulcers don't heal, what we miss upstream, and why local treatment keeps failing. This is my disclosure. The venous ulcers fail to heal when the venous pressure remains chronically elevated. The local wound care treats the symptoms, not the cause, and the persistent venous hypertension prevents the durable healing. Until the pressure dynamics are corrected, ulcers recur. The venous disease cascade, the valvular incompetence, which causes the venous reflux, which causes increased venous column pressure, and the failure of the pressure reduction during the ambulation. So what causes venous hypertension? The structural cause and the functional failure. The structural cause is venous obstruction like May-Turner syndrome, and the valvular incompetence are superficial and the deep reflex, and the functional is increased venous volume, calf muscle pump dysfunction, and the failure of the pressure reduction during ambulation. All this causes sustained venous hypertension, which in turn causes the venous ulcer. So the consequences of the venous hypertension, there's a microedema and the macroedema. The microedema causes capillary hyperpermeability and the leakage of the fibrinogen and the plasma and the leukocyte, causing the trapping and inflammation. The macroedema causes secondary limb swelling, increased interstitial pressure, reduced oxygen and nutrient diffusion, and the mechanical stress on the skin. In this environment, dressing and the topical care do not reduce the venous pressure. Exudate increases as edema worsens. The VAC therapy manages the fluid, not the hemodynamics, and the upstream pressure problem remains unaddressed. So surgical correction is helpful, but incomplete. The iliac obstruction, superficial reflex can be corrected. However, the reflex below the knee often persists, and the calf muscle pump dysfunction remains, and the venous pressure during the activity may not normalize. Why common symptoms often fail in the real world? The elastic compression, which we normally use right now, there is no quantitative pressure measurements. There's inconsistent application. The pressure decays over time, and the limb volume changes, reduces effectiveness. And the elastic system prioritizes the resting pressure over the function. What is the ideal compression must deliver? It should be inelastic, that supports the calf pump during movement, and the easy to wear drives adherence, constant and consistent, maintains the therapeutic pressure over time, and it should be measurable, allows objective dosing and adjustment. So the effective management requires a combined approach to treat the anatomic cause of the reflex or obstruction, and correct the abnormal pressure dynamics during rest and the movement, support venous return, lymphatic clearance, and maintains reproducible functional compression. What we learned from the prior studies, there were two important pivotal studies done. One is ESCAR, another one is EBRA. ESCAR was not proved to be good because during that time in 1990s, it was done ligation and stripping, and most of the people could not get this surgery. But once the EBRA happened, when the endovenous ablation improved the healing, that showed, because of the endovenous, it showed improved healing and reduced the recurrence. But there is a problem with this, with the limitation of the stage treatment, because it requires multiple procedures over time. It causes delayed pressure correction, ongoing tissue injury between stages, and increased burden on patients and providers in doing multiple stages, because we do from knee to the thigh and we don't address below the knee at the same time. So the single session solution should be treat the truncal, tributary, and the perforator reflex all in one session. Avoid prolonged stage intervention and rapid reduction in venous hypertension that causes early restoration of pressure dynamics. So this is one I'm going to show you, a video. Can you show the video, please? Can you go back? One more back. Back. One more back. One more back. Back. Yeah, this one. Can you play the video, please? Yeah.
Weeping ulcers accompanied by significant edema. These ulcers have been persistent for 15 years without resolution. Utilizing a retrograde approach in this case may reduce the need for secondary interventions and promote a faster, more comfortable healing process for the patient. Here is the process. Using ultrasound guidance, a 22-gauge needle is positioned 3 to 5 centimeters from the saphenofemoral junction. At the access site, a 0.018 short guide wire is inserted, the needle is removed and a 7 French introducer sheath is then positioned into the superficial vein. A 0.035 guide wire is inserted through the sheath. A 4 French angle or straight angiographic catheter is then flushed and follows the guide wire into the sheath. With ultrasound guidance, the catheter is placed into the most distal portion of the saphenous vein, and the guide wire is removed. The patient's leg is then angled upward at a 45-degree angle and the polydocanol microfoam 1% is then slowly injected into the venous structure while taking out the angiographic catheter, allowing the whole superficial venous structure to close. Antegrade treatment strategies frequently require multiple sessions, which increases both the procedural burden and the overall cost to the patient. In contrast, this proposed technique involves retrograde closure of the truncal veins along with all secondary branches feeding the ulcer bed, providing a more comprehensive and efficient approach to venous ulcer management. Compression therapy and appropriate wound care should be maintained consistently until complete ulcer healing is achieved. Postoperative duplex ultrasound confirms successful closure of the truncal vein and its associated tributaries, indicating an effective treatment outcome.
Now, talking about the compression, as I said, ideal compression should be inelastic, easy to apply. And this one, we came up with this wrap, which has got a non-sticky contact layer, gel fiber, which absorbs a large amount of fluid, adjustable inelastic compression, as you can see, the bladder and the third one, and you can adjust the dosage from 20/30 to 50 millimeters of mercury just by pumping the hand pump. And it's easy to put on and taken out by any unskilled person. So this is the patient, real patient. This is from Jamaica. He came in to see me. He's been there for 15 to 17 years, he said. I saw him in end of December. And so he was only with me for 3 weeks. And I did that retrograde procedure on this patient and gave him the treatment and sent it with him to Jamaica. Now this is the treatment follow-up. It's about 5 weeks. This is the healing process on the 5 weeks. So this, I'm going to skip this. You don't have any time. So we did about 10 patients and 12 limbs. As you can see, most of them healed in 2 to 8 weeks. And some of them are healing in the real process because they are still in the active stage of healing. So why this technique is different? It addresses veins not injectable directly, because particularly when there is a large ulcer bed and complex below-knee reflex, and it treats the entire reflex network. The key takeaway from experience is a single procedure can treat the truncal reflex, treat the tributaries simultaneously, avoids multiple stage intervention, and supports faster healing. The venous ulcers, so what the technique is most full when there's a superficial truncal reflex, non-occlusive chronic venous insufficiency, and the patient's poorly suited for multiple procedures. So the key takeaways are the venous ulcers are driven by abnormal pressure dynamics. Downstream alone cannot overcome the sustained hypertension. Reflex treatment is necessary but not sufficient. Single session reflex correction plus functional compression changes outcome. Thank you so much. Show you a different technique.